which we brought over to India, and we've used it for the first time in our country in January this year. It's hand fenestration of stent grafts, which I believe is very relevant to a third world country. As we all know, stent grafts occlude side branches both at the landing zone of the graft and in those arising from the aneurysm, and it has been well described that you can actually hand fenestrate aortic grafts, and this is credit should be given to Doctors Ricotta and Odrich, who are originally at Mayo Clinic. This is how it looks. They make a hand fenestration, and when they deploy it, they line up that fenestration to the side branch and put in a small stent graft through that and seal that region, preserving flow into the side branch. And this is how they do it. They use ophthalmic cautery to burn a hole in the graft, sew the edges with a radiopaque wire, and then reload the graft and deploy it. So this is essentially what we did in January this year. A 33-year-old male who came with epigastric and back pain. He had dilated cardiomyopathy earlier on, but that had recovered, and he had actually Takayasu arthritis with carditis, and he still had high inflammatory markers, ESR, CRP high, but his peripheral pulses were well felt. So our procedure was done on the 18th of January. He had a large thoracoabdominal aneurysm which extended down to the level of the renal arteries. So deploying any graft would knock off all the 4 visceral arteries if it was done purely by endovascular technique. This is another AP and lateral view of the same. So this is what we did. We planned out this procedure based on CT angiography. We decided where we're going to place these fenestrations on the stent graft. We decided that the 2 renal arteries would be at 3 and 9 o'clock, the superior mesenteric at 12 noon, and the celiac at 2 o'clock. And then we also counted the stents from the top of the graft down and decided where we would place these fenestrations. So this is how we did it. We used ophthalmic cautery to burn this hole into the graft, which has been deployed on the table. We measured the distances from the top end of the graft using a scale, and we used a coronary wire to sew the edges of this fenestration with, and then we used 6-O-proline, which is blue in color, and this is how the fenestrations look. So under fluoroscopy, you can see them as circles. And then we reloaded the graft using umbilical tape, and we also had the top of the graft which has barbs in it inside a syringe so that it doesn't injure the operator. And so this is the procedure. We had to land the graft below the level of the renals. There was a small aneurysm below the renals which we did not treat at this stage. And we initially cannulated all the 4 visceral arteries, 3 from above and 1 from below. The 3 above were from the 2 brachial arteries and from the left carotid, which we percutaneously accessed. So we had these 4 catheters in these 4 vessels, and then through groin cut down, femoral artery cut down, we brought in the stent graft and deployed it. And after deploying it, we accessed each of these 4 visceral arteries with long sheets, as I said, 3 from above and 1 from below, and had these wires going into each of these visceral arteries. And then we brought in stent grafts and deployed them into each of these 4. You can see we are deploying the renal and the superior mesenteric grafts in these panels. And this was the final angiogram. The 4 visceral arteries were all preserved, and the aneurysm was excluded. And we have this final follow-up angiogram, CT angiogram, a month later. You can see who has a hammer, everything looks like a nail. So once we had this technique, we wanted to use fenestrations for practically anything that came along, and for the next 4 consecutive cases, we used fenestrations for the left subclavian, and I'll show you 2 of them. This is a 40-year-old male who came with chest pain and back pain. He had this huge thoracoabdominal aneurysm ending above the celiac artery, fortunately. But we wanted to start this graft across the left subclavian, and we made a single fenestration for the left subclavian, and we came in from the left brachial artery, cannulated it, deployed a stent graft across that fenestration and got this result. You can see how we can start the stent graft right from the left common carotid and get a very nice seal on top, which would have been impossible if we tried to spare the left subclavian. And that's the follow-up angiogram, and this is how it looks on just plain fluoroscopy. You can see that radio-opaque wire going around the fenestration at the you can see it as a horizontal line there. Maybe I can show that. This is, yeah, that's the actually a coronary wire, flexible end of the wire cut and sewn onto the edge of the fenestration. And the last case is a young lady, again with Takayasu arthritis, 18 years old, with the saccular aneurysm of the descending aorta with a lot of tortuosity proximal to that and some dilatation. So we wanted to start this proximal to the left subclavian artery, which is what we did. Got the stent graft coming right into the arch, had a brachial artery access, and you can see the fenestration in the graft up there, like this circle there, and we wire that with a bent catheter, and that's the fenestration being stented, and this is the final result. We can see that we get so much more seal by starting ahead of the left subclavian artery, and so much more satisfactory and stable stent graft position when we have this technology. And this doesn't cost anything more. It just involves 1 hour of work to actually sit down and make that fenestration. So what we do is if we are doing the procedure, let's say today at the end of the day's work, we fumigate the lab and make the fenestration, put the device into a sterile cover, and then do the case as the first case the next morning. So we don't lose lab time either. So we're really excited about this. I think this is highly applicable to our country, where we don't, most patients can't afford custom-made fenestrated stent grafts, and this really expands the range of aneurysms you can treat. Thank you.
How much, what operating time on that first case with those multiple grafts, how long did that take to deploy?
Yeah, we spent the morning making the 4 fenestrations and reloading the graft. And we had the case scheduled for 2 o'clock in the afternoon. So we started anesthesia at 2 o'clock. Patient was wheeled in around 1:30. We were done by 5 o'clock. So that was, it went off pretty smoothly.
Yeah. That's got to be a record, because I know I was talking to some of the fellows down in Australia doing some of the complicated cooks, and they're talking about being there 6 or 7 hours on some of the cases. So
yeah, so the important thing is the fenestration should be done ahead of time, and you shouldn't be tired from having made the fenestration when you start the case. So we believe in doing it a day ahead and start the case with the fenestration all ready to go, kept sterile in a long sterile cover, and we do it as the first case in the morning when the patient is wheeled in.
Any questions from the audience?
How do you keep the graft sterile for that period of time?
Yeah, we have these long sterile covers which we use for ultrasound procedures during...
the sleeves.
Yeah, those sleeves.
Put it inside the
Yeah,
sleeve.
put in that and seal it, and we keep it on a sterile table and cover it with a sterile drape. Yeah. But it's just overnight, maybe 12 hours. That's all.
Okay, we'll move on to the next presentation. Thank you, Professor Joseph.